Günaydın.
Good morning, everyone. First and foremost, there is a very nice weather outside. I'd like to thank you for being with us today. And I'd like to congratulate Mesut Bey. Actually, I agree with what he said in terms of pharmacology and in terms of content and in terms of the foreign speakers. So we have witnessed a very good speeches and presentations. So I'd like to congratulate Mesut Bey. And Professor Mesut actually started off with the prevalence of non-drug compliance in psychiatry. I'll talk about the cooperation in treatment and also why there are problems in the cooperation of treatment. Actually, regarding compliance and non-adherence, I have a slide and I would point this out. This problem does not occur only in us. There is a study published in Lancet regarding cytidines and regarding between the patients who take statin regularly and the ones who drop out regarding myocardial infarctions. There is a study conducted. This curve shows the patients taking regularly, and this curve shows the ones who are in non-compliance. When we say high, it means 80% and above, and middle level of usage is 40%, and when we say low cooperation, 40% and below. And 1 year later, to what extent this slide actually relates to what extent cardiac arrest happened in these patients. In the patients who are not taking statin regularly, or the ones with bad cooperation, that risk increases by 25%. So this is a problem of medicine. It is not only specific to us. In my presentation, I will talk about the factors which actually causes non-compliance. There are two factors important. One is the relationship with the patient and the physician, and the other one is also the lack of insight, and also what can we do in terms of this. We developed a treatment cooperation program. This might have some effects. This is a study in which Turkey is involved as well. The Middle Europe and Middle East and also South Africa were involved in a group, and the following questions asked to the physicians. What do you think, to what extent your patients are taking the treatment, and to what extent you think that your patients are non-compliant? You see that half of the physicians, when they make evaluations of the patients, they foresee that half of the patients take their medications regularly, and if 40% of the patients are non-compliant. When we consider these rates in a closer terms, we see that in Turkey, 337 psychiatrists were involved in this study. Some of you might have. And in 26% of the physicians in Turkey think that 26% of their patients are non-compliant to their treatments. And it's very close to the figures which are presented by Professor Mesut. So what does it mean to have non-compliance, and what are the results on the patients? The most important result is hospitalization. And we see the hospitalization rate difference between the ones who are taking regularly and who are not, and there could be relapses. And in clinical table, there is an apparent relapses, and there could be substance abuse and violence, and there could be some emergency cases as a result of non-compliance. There are two concepts which was discussed in the previous presentation as well. It was first defined as compliance, but then there came adherence. Compliance actually is the extension of a general medical education. there is the physician, and the physician thinks what is right for the patient and what is expected from the patient is to comply to the treatment regime. So this actually relationship had a negative effect on compliance, and there is adherence, and the patients now are able to receive information regarding the medications, and they can review the advantages and disadvantages. So the position of being a physician also changed. So we are not somebody recommending something, but we are the ones who are making evaluations regarding the patient and also come up with different alternatives regarding the treatment, and we expect that the patient is involved in treatment as well. If such a cooperation is established, the patient will take the chances of taking medications regularly increasing. When we were developing this our program, actually we discussed which concept was appropriate for Turkey. Actually, with there's compliance and adherence. What I liked, actually, the treatment cooperation was better like. So both parties, both the patient and the physician, they should be in cooperation with regards to their treatment. What are the reasons of cooperation in patient? There are some reasons which are related to patient. Insight is the most important reason. 1/3 of the patients have deteriorated insights. Mesut Bey presented the results. He said 40%, and when there is a lack of insight, it is related to cognitive evaluation, definition, and the memory functions and attention. It's closely related with, and the other things is feelings, emotions of the patient regarding if there are some negative feelings in the patient regarding the physician, regarding the treatment. The chances of taking medications on regular basis decreases a lot, and the other one is that the treatment is not effective. It is very normal. If you have a treatment plan and if there isn't any improvement in the symptoms in your targets, so it's very difficult to expect that the patient continue. So when the treatment is not efficient, has not efficacy, the patient actually drop out. Taking the drugs. In KT study, it was within the context, and one of the reasons for quitting was the not efficient treatment and their adverse effects. If there is an adverse effect, for example, there is a weight gain in the young patients, it might be useful not to expect that the patient continues the treatment. And the other one is the cooperation between the physician and also the patient. If the patient, if there's a problem in this relationship, if the patient has some doubts and does not trust you, if the patient thinks that you are not understanding that person, there could be problems. Sometimes the patients, because of the relations, sometimes the patients, continue taking their medications. The other important factor is stigmatization on the family. The families can have direct interventions on the drug usage. There could be denial and ignorance to the treatment, and there is a general stigmatizing attitude in the society, and this makes it harder for patients to continue their drugs. There is a recently published overview in bipolar and schizophrenia patients. The treatment, the reasons preventing the treatment cooperation. These are common factors for bipolar and schizophrenia patients. When we consider the demographic characteristics, a young age, low educational level, low conventional life, and also being in a minority. These are the basic factors deteriorating the cooperation. The lack of insight, cognitive deterioration, and also lack of agreement regarding the treatment also deteriorates the cooperation. There are two important symptoms. One is there could be a high level of hallucination and also doubtfulness and also substance abuse. And regarding the obstacles regarding the treatment and also the negative feelings when they start the treatment also have an effect on this. There are some factors specific to bipolar disorder. There could be severe affective symptoms, mania or depression, and also full-blown mania and mixed episode and severe depressive attacks, frequent suicidal attempts, and the long extended time of these attacks and psychotic crisis can prevent the cooperation. If there is an OCD or anxiety disorder in this patient, this also has an effect on the treatment. The side effects, sedation and weight loss, actually are the ones, those of the important factors for schizophrenia. What are those? The severe depression on the onset, and also dysphoric response to the treatment, and also have a certain attitude to treatment, and presence of positive symptoms, and also not efficient treatment, and the adverse effects actually deteriorate the treatment cooperation. In this study, there are two important parameters that they are apparent in this study. In schizophrenia patient, what is the most important factor for non-compliance? The first factor is found out to be a lack of or deteriorated insight. It has a risk of 12-fold more, and the other effect is the adverse effects, and it has a 20-fold effect, a higher effect. So if your medications are not effective in the patients, and if there is a lack of insight in the patient, and if there are adverse effects on the patients because of these medications, it will be very right to foresee that the patients will quit these drugs or discontinue these drugs. So what is the perception of psychiatrists in this area regarding the reasons of discontinuation? This is ATES study previously shown. You can see the European Union, Middle Eastern data, and Turkey data. Turkey and European data are overlapping with each other. And in Turkey, the physicians, in their opinions, they think that there is a lack of insight in 40% of the patient, and that is the reason why there is a discontinuation, and adverse effects are important. This is the opinion of the psychiatrists regarding the patients, and also the feelings of the cognitive lackings problems are the other important factor. I'd like to talk about substance abuse. If there is an accompanying alcohol addiction or abuse or other medication, the rate of discontinuation is very high. The long-term injectable medications should be taught as a first option, because in treatment process, the rate of discontinuation most probably will be very high. Amadoglu is actually somebody working in studying the issues. The lack of insight is similar to anosognosis. If there is a lack of insight, if the patient does not accept that he is sick, and then it will not be very right to expect that the patient will continue. Regarding the deterioration of this insight, the physical factors and the memory functions, they're on the upfront, and they have negative effect on the compliance. and the insight is related to memory disorders. If there is a lack of insight, it will not be very well for us to expect the patient will take the drugs. And the other factor is the relationship with the patient. If that is not appropriate, the patient will discontinue. So what they expect from us, we need to listen to them without any judgment, and we should understand their point of view of quitting the drugs, and the secure, safe relationship established with somebody who's expecting benefits from taking medications. So when you consider the daily practices, when you see 60 or 70 patients, and if there is a significant amount of patients who have deteriorated cooperation, this time allocated to the patient should be higher. And during the examination, the time that you're going to allocate to a patient might increase the trust of the patient towards you. And some patients, they just take the drugs because they trust us, not because they are sick. And we can't expect any understanding from the patient's side, or any obedience, any belief that these are right. So what to expect from them? We can expect that they will be angry to us, and they will be skeptical, and we can expect that there will be disobedience. Amador actually studied the issue very much, and he also started an institute out of this, and he also delivers trainings in the channel of money, and he is quite successful. Amador's success comes from his own story. Amador's older brother is a schizophrenia patient. Amador pointed this out in the meeting, so I'm telling this. There was a hospitalization and a relapses in the older brother, and with the long-term injection, the hospitalization actually came to an halt. When he was away, Amador asks his older brother, "You're taking the medications? What do you think of your disorder?" And the patient says, "I'm not sick. Only because you want, I'm taking the injections once in a month." Amador's technique is about how to approach a patient who's not accepting the treatment. First, you need to listen to the patient, what the patient says to us regarding what he experiences regarding the disorder, and we need to then try to empathize with the patient, what kind of an emotional state the patient is in, and what the patient wants, and then not regarding the disorder, maybe not regarding treatment, but you need to agree on the benefits of this. I had a patient who was a university student. He gets into a fight into somebody coming from southeastern part of Turkey, then he kicks that person, then he became introvert. He told that this person can be a son of a morphitic person from the southeastern group, and he thinks that that person is looking for him, and he closes the curtains to check whether there are any black cars, because mafia uses black cars, and if there is a black car in front of the building, he gets he gets high level of anxiety. He does not want his parents and his brothers and sisters to go out, because he thinks that the people in the black cars are going to kill them, and he never thinks he is sick. I started olanzapine in this patient. He took the medications. There was healing, and this ideas actually are partly continued, and then he said that I'm not taking this drug because I'm sick, because I want to sleep better. So this is the agreement regarding the psychotic treatment. I told him that it's a good sleep medication when he The symptoms were better. He quit, but then he understood that it was regulating his sleep motor. So you don't have to agree on the disorder, but you need to make an agreement regarding something beneficial about the medication, and regarding daily life, like continue, finishing the school or going back to work, there could be some beneficial effects. And last but not least, and the patients who have compliance issues, the injectable medications, they should be preferred. And there's a problem in the attitude of the psychiatrists. The psychiatrists, they think that the patients will not accept these long-term injectable medications, and they do not present this as an alternative, an option to the patients, because they think that the patients will prefer the oral tablets, because in some studies there could be such a preference in 1/3 of the patients. I ask generally, we can administer 2 types of drugs. One is the regular oral tablets, and the other one is the injectable injections, which will be administered in once a month or every 2 months. So the psychiatrists, they consider this long-term injectable medications as the last option in the patients. So it prevents efficient use of these drugs. The most important reason is that there is a lack of insight, and there could be a non-appropriate therapeutic agreement. This is one of the other factors preventing the cooperation. You need to discuss the appropriate medications, and in all the schizophrenia patients, actually it might not be very feasible, but you need to involve the patient and the family, and you need to involve the family to the treatment plan. If you skip the patient family, if you do not involve them in the treatment, and you will ignore one of the most important adverse effects. You need to ask the family how it is going, and there's a high burden on the shoulders of the families. In most of the families, the families can have express very negative thoughts, and you need to involve the family to the treatment, and it's very useful for the efficacy of this treatment. Thank you very much for your kind attention.